The first surgery I ever did by myself, I cut a man's leg off. Not one, but two freaking legs. Yeah, and I cried afterwards. Welcome to your life as a surgeon. There I was, a newly appointed orthopedic surgeon on a locum in Timmins, Ontario. And I find myself in the operating room with a man who needs a double leg amputation.
It was at this moment that he knew he fucked up.
Buckle up, interns. Today's lesson isn't for the faint of heart. And before I tell you how to amputate a leg, let me give you the backstory. Timmins is a relatively small town in northern Ontario, the province where I live. It has very cold winters. You know, the stay inside because it's not really suitable for a walk around the block kind. Like minus 35 degrees Celsius. Or like minus 31 Fahrenheit for you Americans. Every day. Now, I'm not from Timmins, and neither was my patient, a homeless man who had hitchhiked 719 kilometers, or 447 miles, all the way from Quebec up into the winding highways of northern Ontario. The local police were very surprised to find a lone man trudging along an empty stretch of road on an exceptionally cold day. They took him into the cruiser and asked where he was from and where he was going. As they drove, the man started to warm up, and the police noticed an interesting aroma wafting off the man in the back seat. Well, interns, have you ever smelled rotting flesh? Type that question into Google and you'll get an answer that belies the visceral sensory impact of the real thing. Rotting meat with fruity undertones. Gross. But in real life, truly barf-worthy. At the time, the police didn't know what they were smelling. They just knew that it didn't smell right, and they decided to bring the man to the hospital to see a doctor. I was just the newbie on a locum. The resident orthopedic surgeon providing coverage for Timmins, Ontario, of which there was only one at the time, you know, it's a small town, was away on vacation and I had flown in to cover his duties. The nurses ran the typical diagnostic procedures and they too noticed the odd odor. When tissue is injured or dying, bacteria fester in and begin to break down the tissue. In this chemical reaction, the rotten odor is released. Our patient seemed okay from the waist up, and thus our search led us down. Like Toucan Sam hopping downstairs on Christmas morning. We removed the man's boots to find two entirely gangrenous feet. Like, they were entirely black. Think mummification.
Mummies.
Gangrene is death of body tissue due to a lack of blood flow or a serious bacterial infection. It commonly affects the extremities where blood flow is less robust. Due to their distance from the heart, it takes blood longer to reach our hands and feet. And this process is slowed in adverse conditions such as extreme cold. Also in cold temperatures, small blood vessels constrict.
In the brain, the hypothalamus tells your blood vessels to constrict,
which is a protection mechanism that reduces overall blood flow to the areas in the extremities in favor of maintaining the amount of heat the body loses. Remember, our vital organs are in here, and they are the body's primary priority. So there I was faced with two blackened feet on an otherwise non-blackened individual, I might add. But it seemed that the gangrenous tissue extended up into his pant legs. We removed his pants only to find that the gangrene had extended further to muscles of the body as it had elsewhere in the muscles of the feet. The entire lower part of his leg, midway up the calf, was compromised, with the frostbitten tissue extending slightly further up his leg. When tissue is frostbitten, ice crystals literally form inside the cells, causing physical damage and permanent changes in cell chemistry. But freezing only kills a proportion of the cells. Some survive. Additional damage occurs when nearby tissue that has not itself frozen becomes anoxic because blood vessels that have narrowed in response to the cold can't deliver enough oxygenated blood to the tissue. This process can be aggravated by small clots that form in the narrowed vessels, slowing oxygen delivery even more. Should blood flow be restored to this tissue, damaged tissues release inflammatory compounds that worsen the damage already present as a result of freezing and anoxia. These noxious substances are released locally and into the bloodstream as frozen tissue is warmed. This does not seem at all pleasant.
This is bad. This is very bad.
Our first order of business was to determine the degree of frostbite and if any of the tissue was recoverable. First degree, irritates the skin and there is pain. Second degree, blisters, but no major damage yet. Third degree, involves all layers of the skin and causes permanent tissue damage.
Alright, must be a long day because I'm watching this back and I just realized I put burns instead of freezes, but I don't know if it matters because the definition looks pretty much the same, right? It's the same definition, right?
Right. So we're dealing with severe frostbite in the fourth degree.
Get 'em.
Everything in this man's leg was frozen.
Get 'em.
If there were a fifth degree, he would have it. Typically, we try to allow some time to see if the tissue will revascularize and pink back up as blood flow is restored. Other testing, such as a CT angiogram, helps us to determine what tissue is still viable. This test involves injecting an intravenous dye into the body and then running a CT scan. This combination produces pictures of blood vessels and tissues in the target part of the body. So after we'd allowed for some time for the tissue to revascularize, our CT angiogram showed that there was only blood flow to about mid-shin height. Literally everything below that was dead. It looked like he was mummified like black leather from mid-shin down. Modern science can do amazing things, but not this. Even in the event that we could do a vascular graft, taking the blood vessel from one location in the body and then transplanting it into the damaged legs and feet, the tissue in the target site was too far gone, shriveled up too much to be a suitable receptor site for a donor graft. So, amputation, my favorite. Not. Amputation is a complex procedure that involves severing all the varied tissues, which heal in their own particular manner, in strategic order, so as to create the most functional residual limb possible. Limb loss is not only a physical and functional loss, but an extremely psychological event and emotional change for the patient. Our limbs are how we interface with the world around us, and in the case of our legs, our primary mode of transportation. First, we must determine what level to cut the leg. Legs. We must consider what is going to be the best location in terms of making a stump for the patient. There are many prosthetic options available, but we aim to create the longest stump below the knee whenever possible, as this type of prosthesis requires less energy expenditure when walking than does an above knee prosthesis. It is also easier to fit a prosthesis on a lower extremity than it is the upper extremity. And with a mid-shin height amputation, at least our patient would have enough length to give a good fit in his legs. When fitting a prosthesis, approximately 20 centimeters or 8 inches of length will suffice. That's the length at which we will cut the bone. And no, an amputation procedure isn't as simple as one straight across, flesh, bone, and all. We need to have enough soft tissue and skin to cover the end of the bone. In our patient's case, that means that we must amputate at a height that the surrounding skin and muscle tissue is viable and not damaged by frostbite. At this level, there are no tendons to worry about, but the procedure must still follow a stepwise approach that addresses each tissue involved. First the skin, then the muscle, and finally, the bone. Put your hand up if you've heard of a fish mouth incision. This is a type of incision commonly used in the amputation of limbs, where the flesh is used to create a front flap and a back flap, resembling, of course, the mouth of a fish, where the back flap is slightly longer so that it can wrap around the bone and stump and be sewn to the front flap. Once the amputation is complete, the skin flap will be sewn onto the top of the reattached muscle. So both skin and muscles must extend around the length of bone remaining. Once the initial incisions are made, we'll sew in a drain that we can pull out afterwards. Combined with tight wrapping above the amputation site, this will help us to control bleeding as much as possible after surgery. The drain will be removed later on once bleeding has slowed to a manageable level. As the surgeon works their way through the muscle, they must tie off and ligate the blood vessels, which is to close them up for good. In ligation, a blood vessel is clamped with a hemostat, and a suture is very literally tied around the vessel. They must also carefully sever the nerves in the region to help the patient avoid painful neuromas. A neuroma is the intertwined mass of scar and nerve tissue at the end of a severed nerve that can be painful to pressure, stretching, or physical manipulation. Since the amputee's limb will be subject to all of these forces inside a prosthesis, it is important to limit this as much as possible. University of Washington's Department of Sports Medicine discusses several tactics that have been devised in order to minimize neuronal formation, though none have proven uniformly successful. Nerve ends may be cauterized with chemicals or heat.
We're going to pour black powder with the main ingredient of saltpeter into an open wound, and then we're going to set it on fire.
Buried in the nearby bone, encasing the nerve in an impervious material, ligating the nerve, or injecting it with a variety of chemicals.
It goes without saying it should not be done at home.
Other methods include sewing the section nerves to other nerves or sewing them back onto themselves, thereby creating a nerve loop, and even simply dividing the nerve and allowing it to retract.
Not a physiologist, I don't know anything about exactly where veins are at.
In my case, I ligated the nerves, sectioned them carefully, and allowed them to retract away from the outermost region where pressure would be the most apparent. If a nerve can be positioned in a well-cushioned soft tissue site away from the incision and scar tissue, that bodes well for the comfort of the amputee. Now, once the nerves and blood vessels have been addressed, it is possible to sever the bone. We have different kinds of saws for this, but typically we will use an oscillating bone saw. Fun fact.
Hey guys, so today I'm going to be looking at facts that are not fun.
In the old days, we used to use something called a jiggly saw, which is a flexible wire saw that you power with your hands. Talk about an immersive experience. You can literally use a hand-powered wire saw to sever bone. Another fun fact, in some detailed procedures where precision and control are particularly pertinent, they are still used today. They allow for smooth, even cutting, especially in small, sensitive areas. Remember that we are creating a stump here. So this bone is cut shorter than the surrounding muscle and skin flaps, allowing them to be stretched around the bone and sutured together. But before we get to that, we'll typically bevel the front edge of the bone at approximately 45-degree angle to give it a little bit more of a gentle contour on its front edge so that the tissue inside the stump is protected. And finally, with the bone severed and beveled, it's time to put everything back together.
Maybe we could put them together again.
But where would we start?
At this phase, the muscle is attached to the bone in a process called myodesis. The surgeon will either drill holes through the bone and suture the muscle directly to the bone, or secure the muscle over the bone and suture it to the periosteum, which is a thick tissue that covers the bone. Then the surgeon will close up the fish mouth incision around the end of the bone, and as you recall, we left the back flap longer than the front flap just for this purpose. In our patient's case, for a mid-tibia amputation, this means that the soleus and gastrocnemius muscles will be attached to the front of the tibia. When the muscles are attached in this way, they pull against each other, creating tension and preventing the muscles from shortening or retracting further up the leg. Either way, once the muscles and bones are secured in place, we can continue the procedure by sewing the skin shut over the amputated limb. And after all of that, I only had to do it one more time. So, how was that?
You know, I was telling my husband before I left, I says, I don't know what these guys are gonna do.
You didn't know what we were going to do?
But I just know my legs are going to feel so much better. And they do. I can honestly say my legs feel great.
What legs? Oh my God! An experienced surgeon can complete an amputation procedure in approximately 15 minutes. The fastest I've ever seen it done was by a vascular surgeon during my residency. He used a Lister knife, which is the tool that Jack the Ripper used to kill everyone, which is basically a mini machete. And in a couple of deft cuts, he sliced through everything except for the bone. Along with the other surgical assists, I clamped hemostats to the exposed blood vessels as quickly as I could. There was blood everywhere before I could get 8 or so clamps hanging off the end of his legs. I was the snap release guy as he sequentially ligated the vessels in a whirl of surgical expertise. And then, can you guess? He whips out the jiggly saw, of course, and severs the bone in approximately 30 seconds. Suture it all up and we're out of there in 10 minutes or less. Unlike my patient up in Timmins, his patient woke with only one leg missing.
First time.
But I'll tell you what, my guy was ecstatic. even though both of his legs were amputated below the knee, he was now going to be eligible for disability from the government, which would at least afford him a place to live. To him, that was a superior option to living on the street as he had before. And after that, I cried. Because, you know, I cut off both of his legs as my first surgery.
So we just tried out this new concept, trying to prove that doctors are people too.
Yeah, and that was my first surgery, working alone as an orthopedic surgeon. Welcome to your new life.
You look beautiful. Congratulations, and I hope that you're enjoying this new life.
Let me know what you want me to discuss next. As always, that's been a word from Dr. Chris, not your everyday ortho.